At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and Happy New Year. I am Donna R, the founder and CEO of the Global Liver Institute, and I have the great privilege of being your host for GLI Live. We are starting off January with a topic that we have been told we have under-addressed. And so we do listen to you. And so we are starting off the year on the topic of dry January and alcohol-related liver disease, which is very top of mind for many people all year round. And so to help us with that, we are going to talk with the editor-in-chief of Hepatology Communications and one of the top communicators in this or any field, Dr. Elliot Tapper. Hello.
Hello and Happy New Year to you.
Thank you. So, Dr. Tapper, can you tell us how you got involved in hepatology and particularly what led you to lead your special group on cirrhosis at Michigan?
Well, I am a hepatologist at the University of Michigan, and I focus on the care of people with cirrhosis and complex liver disease. I spend a lot of my time doing research, which is largely focused on clinical trials that help people with cirrhosis live better and longer. And I've been a card-carrying hepatologist since the first time I met a patient who had a liver transplant, and they got me hooked when I found out that it was such a powerful, transformative organ, and the care of it was so exciting and rewarding.
It is indeed. And thank you for validating all the med students that I try to co-opt anytime I'm in or around a hospital and try to tell them how amazing hepatology is and wouldn't they like to have other people, last 30 more years of life as my transplant team is able to give me. So I'm glad somebody scouted you out early. You have been a credit to the field. Like, how do you respond to that? I know it's hard. Like, nobody gives you compliments. I feel so much like nobody compliments hepatologists enough. Did you know you had a fan club? That's the card I carry, the hepatologist fan club card.
I am certainly your fan, and we definitely, if hepatology and liver transplant had a celebrity and a mascot, you would definitely be it. You're exactly what we want, what we dream of every time that we consider liver transplant and we think about the future for our patients. So humbling your comments are, but the truth is, we know who the star is here.
Thank you. My personal theme for 2024 is a hashtag, of course, because we sort of interacted with each other on Twitter, now called X, and it's called hashtag Make It Make Sense. And you do that so often for so many different topics in liver disease, particularly destigmatizing a lot of things that liver patients of all stripes go through, but particularly for those with alcohol-associated liver disease. What are the challenges that patients with alcoholic-related liver disease face in your experience and practice?
Well, this is such an important part, and there's a few components to your question that are worth addressing. The first is that there's a lack of great education that's immediately available to people, and we have a little bit of a marketing problem. And because people tend to suffer alone or in silence because of the stigma associated with liver disease, it's harder to point them towards trusted resources. And so we've worked really hard at the University of Michigan to build resources with patients that we think provide them with the kind of empowering education that they need. But we still need help connecting people to that kind of education. And if I had the opportunity to reach a person when they received a diagnosis of alcohol-associated liver disease, the key message that I would want them to know is one of hope. which is that the liver is often regenerates. It's never too late to stop. Even the people who are the sickest often recover a great deal. And there's so much to look forward to: feeling better, living longer, with reduction in alcohol use, and understanding that they are not a lost cause and that there is a bright future ahead for them.
I think that that's so important. You know, I drive a hepatic burgundy car with liver lady license plates, just to show people that they don't have to be ashamed of having had a liver disease or having a liver disease or having had a transplant. And I encourage people to walk up and have questions, and they do. And so I think that that open door policy of having people not fear that they have to be alone and suffer in silence is a really important first step.
Completely, right? And so we want to learn not only how best to communicate it, but also we kind of want to game the search algorithms so that when people are typing away at their Google search bar, that the first things that come up are A, trusted resources, and B, ones that provide them with the information that they need to move forward and take the best care of them, and C, hopefully build a community around that.
We've helped, hope that people feel welcome at the Global Liver Institute. And I know that sometimes when, people learn that I came from an autoimmune route, they're like, well, you could never understand. I said, but I'm listening. And there are many people who have participated in our Advanced Advocacy Academy who have come through different types of substance abuse issues. Some have transplants, some not. Many of our patients with viral hepatitis have also had alcohol-related liver disease issues. And so, you don't know until you, come and be part of the family. But I know that we can do more. And in talking with those patients, and thinking about doing, expanding research in that area, I know that the same type of education or supports and services that would be appropriate for a patient or family with autoimmune liver disease is not sufficient for someone who also may have sobriety issues or substance abuse issues, and that we need to rise up better, both as an advocacy community and as a researcher community, to make sure that people are not excluded from trials or treatment, but even the trials, because we haven't given the same type of support that's necessary and tailored for them.
Could not have summarized it better.
So how do you do research? How do you how are things done differently or changed? You talk about putting out education with patients. I think that's a start, but how does your research support patients or people who are living with alcohol-related liver disease just a little differently?
Yeah, so my research is not focused specifically on the management of the alcohol use disorder, and I think that's worth discussing, but my research is pragmatic, and it's built from the grassroots with patient input. And I'll describe that in two ways. The first is that oftentimes when you think about clinical trials, you think about very stringent inclusion and exclusion criteria to create the optimal experimental situation that you can test the impact of things very carefully. But instead, what I do is I take people as they are. I enroll the average representative patient from across my clinic, and I try to do so in such a way that doesn't deprioritize people who have transportation difficulties or have difficulties participating because they work and they have to work multiple jobs. So using things like remote recruitment, electronic symptom-based measurements, and interventions that can be done in the comfort of one's own home, at a time that works for them, that allows me to enroll the kinds of patients that we would call generalizable. The second thing I want to bring up is that I involve my own patients. I will say I'll have a visit with a patient and I'll say, hey, what you've been going through, a lot of other people do as well, and it will bring them on as paid consultants as part of the study to help design the study. I will show them the intervention and say, how could we make this better? I will show them the informed consent form and say, how can I make this better in such a way that I won't scare people away, but I'll also adequately inform them about the risks and benefits and the responsibilities of being a part of a study. And in doing so, I've learned a ton about research, but also more importantly, I've set up studies that are destined for success because they're designed for the patients that by the patients, and they're set up in such a way that we can just run with it.
I think that's fantastic. That's been a lot of my life's work to help partner with physicians to create trials that people actually want to be in, and to leverage, patient expertise and family expertise, to that end. And it's exciting that it's greeted with less and less, skepticism that we might have something to contribute to research. So I'm excited about your uses of patient-partnered research or community-based research. It's certainly something that a lot of the patients who go through GLI's A3 are very interested to learn how to do. And so, we break down what's a protocol and informed consent and give a lot of those in those tips to sort of democratize the types of things that you've done. One of the questions that I wanted to ask, specifically about alcohol and the confusion around the rules, as some people say, like, how much are you supposed to drink? What's a regular drink? And I think in January, everybody, whether they have a liver disease or not, if you have a liver, you need to sort of pay attention, is trying to rethink their relationship with alcohol. When I was in Europe, I sort of half jokingly mentioned that one of the things to deal with is that Americans don't know what a gram is. So giving us instructions in grams is really sort of useless. Because we don't know what a gram is. But can you just talk to people about what, the official guidelines, are currently saying about drinking?
Yeah. So, official guidelines, as you say, are largely drilled down on units of alcohol, 8 grams of alcohol, which, like a glass of wine is about 1.5 units or about 12 grams of alcohol. A pint of beer, about 2 units, about 15, 16 grams of alcohol. And if you try to add these things up, we're trying to avoid a situation where women are drinking 7 units and men drinking 14 units of alcohol in a given week. But increasingly, you'll start to see groups like the World Health Organization drill down even further to say that less alcohol is better. And at the end of the day, the truth is there's no hepatologist in the world that's recommending any alcohol. And in clinic, I'm not asking people about grams. I'm asking, do they drink, what they drink, and then how often they're going to the store to get at a better sense of just what their consumption is. And I might tell them, I want you to drink 0, but I'm always, any amount of reduction is still going to be met with significant health benefits. So I'm trying to meet the patient where they're at, understand what their consumption is, and then come up with some smart, simple goals that we can reach in a timeline that works for them. My conflict of interest is I want 0 alcohol, and we'll try to get to that by tailoring it to the patient's particular current consumption patterns.
I often tell patients from a variety, just friends and family in general, it's okay to have a license, driver's license height and your medical height, or a driver's license weight and your medical weight. When we go in the doctor's office, I'm going to need you to use your medical height, your medical weight, your medical level of smoking, your medical level of drinking. The doctor needs the actual truth, not the sort of Instagram version, to be able to treat you. This is a time for total honesty, and nobody's judging, but we can't do what's best for you if you're making just sort of giving fictional versions of yourself. So that is my counsel to everyone who has interactions with the healthcare system, that no, and yes, it is 5'6", it does say 5'6" on my driver's license. No, I am not 5'6", and that's what, and in the doctor's office I am 5'4.5". So it applies to me as well. But I think that's a very important thing to just, you got to put it all on the table with your doctor so that they can help you meet you where you are. You actually have to be there.
I love that advice. And what I'm going to do is just pivot a little bit and talk about how we handle the amount of alcohol that people drink. So I'm having those conversations so that we can make tailored kinds of recommendations. But increasingly, most people in liver clinic are using actual blood-based biomarkers of alcohol consumption. So, for example, the one that I use, this thing called phosphatidylethanol. For people that have diabetes, it's like the A1C of alcohol. It can tell you how much alcohol your blood has been exposed to over the last month. And I tell people that we're going to use this objective marker of alcohol. And so at the end of the day, they know that I'm monitoring. That might be helpful in promoting behavior. And then it gives us a very objective leg where I'm not trying to say, well, how big are these drinks? I'm not asking them a question, sort of making them feel ashamed about it. I'm approaching them with the objective information, and they know it's coming from a place where I'm not saying, I got you, but rather the door is open. Let's talk about the things that we can do to lower this number overall.
So you can't really study for the test. You have to live it.
Yeah, exactly.
And in terms of living it, it's interesting. I've been so excited to see, and certainly GLI, encourages all of these, non-alcoholic versions of cocktails, that are, vibrant and exciting, and can make people, feel a part of the different, celebratory and community groups that they're in, without, I don't mind walking around with a glass of ginger ale, but, some people do. And so just the, celebration of different, bars and clubs and social venues that are making a special effort to, use really high quality ingredients, or make it so that, people who, choose not to drink for whatever reason, can still be a part of the fun. And so has that been helpful to your work? Do more people sort of mention that they have an easier time?
Yeah, so I think one of the things that people worry about the most when contemplating a month or a life without alcohol is how they'll negotiate these social situations. And for many people, that's just how they hang out with their friends. And then, but everybody will think about the special occasions or the parties and so forth. And in many cases, those fears are not well founded, right? Like even a long-standing drinking buddy would be cool if you took a break. But making that leap, sometimes it takes an experience, and that. And if there's a sort of way to bridge you there by having a non-alcoholic beverage, this replacement, then that is perfect. And we do definitely see improvements there. If the bridge there is a sort of cultural moment like Dry January, where it forces people to pause and think, do we really need to drink when we get together? It really only takes a limited experience to realize that it doesn't have to be habitual. It doesn't have to be every time. It's not necessary for us to get together and talk.
Absolutely. I think one of the things that COVID taught us is that going out for a walk can be a way to connect with people, that there are, thousands of different ways. But I'm always asking, like, why are you in my glass? Like, what's it to you what I'm drinking, or or not? If I choose to have club soda with a lime or something like that, why are you up in my glass? You're too close. And so unless you are going to metabolize this for me, then you don't get to choose it for me. I don't understand why you're up in my glass. So maybe I'll just send that message out for people to play, for those who, if they who are who are nosy or have problem asserting themselves and worried. I'll just record that, and you can just play it. if you need be. You mentioned though the blood tests and biomarkers, and I'm sure other people didn't even know were available. Are there other technologies that are either diagnostic or supportive of people with alcohol-related liver disease?
Oh, so these blood-based tests, like there's also urine-based tests. These are pretty good, but they're for the conversation and monitoring that happens in the doctor's office. And then beyond that, what we'll start to see is a proliferation of wearables or apps. And there's some pretty interesting and exciting research which can actually take the sort of trends that the basic monitors of your own iPhone. This is research out of the Mayo Clinic, where it can track just how many times you're moving around, how many times you're opening your phone, how long you're spending in text messages. And it has been correlated with cravings for alcohol. So these sort of social and behavioral and physical patterns, they correlate actually pretty strongly with a tendency to want to have a drink. And so the hope is that we can deliver at the point of care just in time some feedback and say, looks like we're that you might be interested in alcohol, or I'm worried about you. Why don't we take a pause? Why don't you get a little buzz on your Apple Watch that says, think about, take your own pulse and think about what kind of support you need at this moment. That's, I think, the future, right? Currently, we're still going to be based looking at support from a doctor, support from a community, and change in the culture. And tools like Dry January will always play a role in that.
Right. I think a lot of people are pushing for Sober September as well. So I'm just like, I'm with it. I'm all for it. As well as making people aware of the different, celebrities and other people that they may look up to who choose not to drink just as a part of their lives. And make sure it is just that, a choice that people can make as part of their overall health and wellness, and that, the liver that we know and love can only take so much. It can't regenerate beyond a certain point. And so we want to, try to optimize it and everything else. I think there is an opportunity with all the wearables and focus on wellness. I have misplaced my Apple Watch, and I for the past 3 days, and I don't know what to do. I have an Aura ring, so I'm okay. I know that I'm still breathing, and my movements are tracked. But I think that having this sort of data that helps you, and also having on point, meditation. I use the Calm app, and it reminds me to, to stand and breathe, or just sort of check in with myself at moments, are all good things to, to have at our, at our fingertips.
So what you're describing are two things. One, that there's that first time that you make that choice. And Dry January's key strength is that it invites you into a safe space where a lot of people, there's a whole community that are making that choice either for the first time or doing it again because they felt good. But the weakness of Dry January is, how do we support people and reinforce these behaviors moving forward? Because we live for more than just that 1 month. We're 12 months a year, okay? And it seems like, talking to you, you have a lot of skills that you would want to transport into those people for whom we're hoping for a behavior change. So what kind of supports does somebody need to take that January into February? And at a minimum, it's about reinforcement. When people stop drinking, they tend to feel better. And there needs to be some tools to help say, hey, have you noticed that maybe you've lost some weight? Maybe that your sleep is better. Maybe your tummy feels better. And using all of those cues as a way of feeding it forward. But for the people who maybe still continue to struggle, we still want to be able to link them to care. And so moving forward, we either need something for positive reinforcement or additional supports that we know are evidence-based that will help those people carry it forward through the rest of the year to follow.
Absolutely. People, and by people, I mean hepatologists, those are my people first. People are talking about ALD, or, metabolic associated alcohol-related, liver disease, is having your disease formerly known as NASH colleagues, now interested in the alcohol-related literature. Will that be a boon to your research and your work and bringing attention? Will there be more collaboration potentially between perhaps just other hepatologists and gastroenterologists, but maybe even endocrinology and primary care? Can we use the inclusion and the creation of Met ALD to widen widen the tent or open the umbrella?
So what you're talking about is this movement that happened where, with patients involved, there was a redefinition of terms where we no longer refer to something as non-alcoholic or alcoholic fatty liver disease. We're less judgmental, and we now we now describe it as a spectrum associated with metabolic dysfunction in the liver. And this is particularly helpful when it comes to this bridge between alcohol-associated liver disease and metabolic dysfunction without alcohol, this Met ALD that you refer to. And it's helpful because people don't live in tight, easy buckets. And it was a completely artificial construct to think of this as two separate worlds that don't interact. And so now, for most people with metabolic dysfunction, alcohol might play a role, and accepting that there is this overlap. In studies of yore, you would see the population described as one or the other, but now we're not going to do that. And once we do that, we can start taking care of patients. We can start addressing the underlying drivers of their liver condition, which for many will be focusing on things like the damage from metabolic syndrome, but also the contribution from alcohol, even at levels that would not have traditionally been thought of as damaging, but definitely cause the progression of disease.
I love it. Reality-based medicine. Even better than evidence-based. Evidence-based medicine is great. I love reality-based medicine even more, and so I'm here for it. So as we go into the rest of this year, as promoters of liver health, as public health, and what should we be thinking about? You're in charge of hepatology communications. What are the things that we should be communicating about? I love that there's the journal about communications in this field. What are you excited to communicate?
The number one thing that I like getting across is how much positivity that we have, and how much hope there is for people with chronic liver disease, and that has never been truer than it is now. This is true in a variety of ways. One, there's more interest from pharmaceutical companies, more positive trials that are showing differences in the outcomes for people with liver disease. We have more people under the tent that are focused on and interested in the health of the nation's livers. And there's more efforts like yours that are getting across this idea that you can live very well with liver disease. Liver disease can get better. Some people need a liver transplant. Some people thrive with a liver transplant, but most people will be better off with the liver that they were born with if they were able to take care of it in specific ways. And now we can use our communication tools to make sure that people know that the liver benefits from taking a break from alcohol. It benefits from supports to avoid alcohol for the rest of the year. The liver benefits from taking that walk that we started to do during COVID times, and all the other things that we'll do for the rest of the body to feel better will also benefit our liver's health.
I think that's fantastic to start the year off on a note of hope. And I look forward to reading future issues of the Journal of Hepatology Communications and everything else that you discussed, Dr. Tapper. I'm really so excited to have had this time with you.
Well, it's a privilege to join you.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.